hypertensive emergency, drugs used in pregnancy with hypertension, and if a patient required antihypertensive who is suffering from diabetes mellitus, more specifically type 2 diabetes mellitus. So first we are studying with the hypertensive emergency. So hypertensive emergency, what is the, how we can detect hypertensive emergency? We can detect hypertensive emergency where there is a accelerated or rapid increase of blood pressure, where there is some end organ damage, It doesn't always depend on how or what extent the SBP or DPP is, but more importantly, is there any effect on the end organ? End organ means if there any effect on brain, if there any effect of heart or kidney. The three major organs, if they are affected by accelerated rapid onset blood pressure. Clear? A patient who has a chronic, already chronic hypertensive, having some antihypertensive, but suddenly there are some symptoms which denotes that there is some effect on heart, brain or kidney, then we have to suspect that is there any hypertensive emergency or not. So in the CNS, it can be present as a hypertensive encephalopathy. In CVS, it can lead to myocardial infarction, but more importantly, cardiogenic pulmonary edema. Another term of pulmonary edema is left ventricular failure, decompensated left ventricular failure. Then there may be aortic dissection, already pre-existing aortic aneurysm lead to central chest pain, detect that there is a aortic dissection. What is aortic dissection? Tearing. Which portion of the tearing of the aorta? Primarily endothelium may lead to the full throttle, starting with the endometrium. Then if there is a post-operative vascular surgery, that can also trigger this type of emergency. In case of renal, it is acute renal failure. It may be lead to eclampsia. What is eclampsia? No. That is pre-eclampsia. Pre-eclampsia is a pregnancy present up to 20 weeks, there is no hypertension. After 20, there is a hypertension. If there is before 20, it is hypertension, that it is chronic hypertension associated with pregnancy. There is no hypertension up to 20 weeks, then they develop hypertension along with not only hypertension, along with there is a proteinuria and associated with the leg edema. These three criteria primarily there. The hypertension in pregnancy detect after 20 weeks, then there is a proteinuria along with that, and plus minus there is a edema, pitting edema. Clear? That is pre-eclampsia. So what is eclampsia? Seizures. So the patient suffering from pre-eclampsia, there may be convulsion in preterm, during the delivery or postpartum, antepartum, postpartum and intrapartum. Convulsion is the eclampsia, and in a pre-eclamptic patient. Pre-eclampsia kake denote korbo? Hypertension in pregnancy detected after 20 weeks associated with proteinuria, and commonly there is associated with also edema. That is pre-eclampsia. In a pre-eclamptic patient, just before delivery, antepartum, postpartum, interpartum convulsion is eclampsia. Clear? And lastly, if there is a patient with pheochromocytoma, pheochromocytoma means adrenal gland excess secretion of catecholamine, or there is some drug, you are taking some drug like cocaine, that can also lead to hypertensive emergency. On the other hand, sudden withdrawal of some drugs like can also result in hypertensive emergency. Example, selective alpha blocker, more than that beta blocker. If you suddenly stop the beta blocker, there is a hypertensive emergency. So these are the cause and associated effect of hypertensive emergency. There will be effect on CNS, effect on CVS, effect on renal system. In pregnancy, that can lead to eclampsia. Some drugs like cocaine, in some situations like pheochromocytoma, can also lead to hypertensive emergency. Similarly, withdrawing of some drug without tapering off. Tapering off আর কোন ড্রাগের হয়? আস্তে আস্তে ধীরে ধীরে কমাতে হয় কর্টিকোস্টেরয়েড, নালে কি হয়? If we suddenly stop the corticosteroid, what will happen? হ্যাঁ, তাতে কি হবে? কিভাবে পেশেন্ট প্রেজেন্ট করবে? Like Addison's disease, presents like Addison's disease, without secretion of the hormones secreted from the adrenal gland. So high BP without acute end organ disease, without, it doesn't case as a hypertensive emergency. There are two terms where there is a accelerated hypertension without end organ damage. One is pseudo emergency and another one is urgency. Urgency or pseudo emergency, where there is a sudden accelerated hypertension without any end organ effect. Clear? So why important? Cerebral blood flow, it determined by cerebral perfusion pressure. CPP is cerebral perfusion pressure divided by cerebral vascular resistance. Clear? CPP means perfusion pressure in cerebral perfusion pressure is the MAP, mean arterial pressure, minus ICP, intracranial pressure. Clear? Why these are important? At MAP to jano DBP plus 1/3 PP. PP means SBP minus DBP. Clear? So why it is important? So there is a auto regulation in the cerebral system. So if it is below or excess of that range, that auto regulation will not be effective. So there will be ischemia, or there may be increased blood flow in the, that can lead to, if there is a ischemia, there is a stroke like symptom, ischemic stroke. If there is a excess blood in the cerebral circulation, then there may be cerebral hemorrhage. Clear? So it is important to regulate that cerebral pressure within that, between that autoregulatory cerebral pressure, and it can be determined by MAP and ICP. If ICP is constant, we can control MAP through the antihypertensive drug. So it is important. Why we are giving antihypertensive drug and how long we have to give that. So this is the range. Right side of this or left side of this, then that can lead to either ischemic stroke or hemorrhagic stroke. Clear? That can present as a encephalopathy, cerebral encephalopathy. So lower limit If they are below the lower limit, there is a hypoperfusion and ischemia, and if the above the upper limit, that can be breakthrough vasodilatation that lead to hemorrhagic CVA. So there need a rapid reduction of BP, but that rapid reduction, how rapid and for how long? So we can lower the BP more or less up to 20 to 25% within 1 or 2 hours, not more than that, because already the cerebral vasculature is auto-regulated within that range. So our target is reduction of the blood pressure, not more than 25%, not less than 15 to 20% within 1 or 2 hours. So for control of this, we have to give some drugs in which route? Which routes are preferred? IV route, very good. 50% lowering limit above the usual mean. Most of the ischemic complication develop if there is a greater than 20 to 30% reduction rapidly. That can lead to blindness, paralysis, coma, death, as well as myocardial infarction. So we have to reduce the blood pressure within around 20, not more than 25, not less than 15, and that is within 1 or 2 hours. Why it is important? Because by reducing this, we can reduce the MAP, mean arterial pressure, and by reducing MAP, we can have that cerebral perfusion that is within the autoregulatory margins. Clear? So after 2 hours reduction, then there is a gradual reduction, that is in days or weeks or months, up to the 140. But first, if there is 220, that 20% means 220, 20%, 200 at 20%, 40, not more than 40. That means then our target will be 160. Clear? Not reduce dramatically 130 or 140. Then there will be hypoperfusion in brain as well as kidney, as well as it can lead to CVA and AMI. After that, there is a gradual decrease of blood pressure within days or weeks or months. That target will be less than 130, 140 depending upon the other comorbidities. So what are the drug urgency? What is urgency? Urgency is the DBP 150, more than 150, or there is accelerated hypertension without any end organ damage. Without any end organ damage is urgency, with end organ damage emergency, and another term is pseudo emergency, where there is a accelerated or severe hypertension without any end organ damage. End organ means brain, kidney, heart. Brain e ki? Encephalopathy that can lead to ischemic or hemorrhagic CVA. Then heart primarily LVF. Other than LVF, there may be AMI, aortic dissections, and in the renal, there may be acute renal failure. Clear? And other than these three, that sometimes that can lead to eclampsia. Clear? So pharmacotherapy. Already discussed sodium nitroprusside in which route? IV route. How they act? They release nitric NO, and nitric oxide released from where? Endothelium, and this nitric oxide acts on where? Smooth muscle of the both arterial and venous. Both artery and venous smooth muscle is relaxed by nitric oxide. That nitric oxide released from endothelium. Clear? And another expansion, it has to be freshly prepared, or if there is already prepared, that should be in a black jar or black cotton or something like that. So sunlight can lead to destroy or dilute this effect of this sodium nitroprusside. It is given in intravenously, not in a bolus dose but as a maintenance dose through a syringe pump regular. So if we have to give a dose is 0.5 to 8 microgram per kg per minute. You doesn't have to remember that for that normal theoretical exam, but you have to remember that average for MCQ purpose around 1.5 to 8, so around 4 microgram, that is not per minute, per kg per minute, per kg per minute. So that is μg per kg per minute. Why it is important? Sometimes nitroglycerin is mg or microgram per minute, but here this is mg per kg per minute, around 4 microgram. If it is 0.5 to 8, the average is 4 microgram per kg per minute given in a intravenous dose with a syringe pump. It is a vasodilator that dilates vein as well as arteries. Clear? They release nitric oxide from the endothelium. This nitric oxide acts in a smooth muscles of the vessels. Nitroglycerin primarily used in a, it is a vasodilator. In which clinical situation is commonly used? Angina, very good. It is first line anti-anginal drug, but due to its vasodilatory effect, more or less very similar to the nitroprusside, they also release nitric oxide, and that relaxes the smooth muscles of capacitance vessels or veins, not very less effect on arterioles, but they have some effect on coronary artery. তাহলে কি জায়গা? They primarily dilates veins. They have very little effect on arteries, but they have some effect on coronary artery. Clear? Their dose is 10 to 250 μg per minute. Clear? That is kg, μg per kg per minute. This is μg per minute, and that is 10 to 250 μg per minute. Nitroprusside along with nitroglycerin can be given, both primarily, but remember that if there is a patient of CVA with hypertensive emergency, and before giving nitroglycerin, we can give nitroprusside in ischemic CVA, we can give nitroprusside in hemorrhagic CVA, but we cannot give nitroglycerin if there is a hemorrhagic CVA. So before giving nitroglycerin in a patient having a symptoms of CVA, we have to have a CT scan that shows there is no bleed. We can give in a ischemic stroke. CT scan of brain, we can exclude hemorrhage, but we cannot exclude ischemic stroke. Clear? So before giving nitroglycerin, we have to have a CT scan report showing that there is no hemorrhagic CVA. So we can give both of these drugs in a combination, rarely required. So first line is nitroprusside, IV nitroprusside, then we can give nitroglycerin intravenously where there is a we can exclude hemorrhagic CVA. Then nifedipine. Nifedipine is a, now what is it? Nifedipine? Calcium DPP, and a dihydropyridine group of calcium channel blocker that can given orally and more commonly in sublingual. Clear? Mechanism of action, calcium channel blocker is the mechanism of action seta. Third drug is nifedipine. Then Now we preferred labetalol. Labetalol is a both alpha and beta blocker. Alpha beta blocker, it is preferred in hemorrhagic severe or patient required neurosurgeries. After that, we preferred to give labetalol. Labetalol, another use is pregnancy, hypertension in pregnancy. Clear? For the alpha blocker plus beta blocker. Dioxide, we already discussed. Hydralazine কিভাবে কাজ করে? Arterial dilator, very good. Clonidine, কি? হ্যাঁ, alpha কি? 1 না 2? 2, agonist না antagonist? Agonist. They cut the sympathetic flow from the CNS. Clear? ACE inhibitor, which ACE inhibitor? In hypertensive emergency, already discussed. Enalaprelate can be given intravenously or parenterally. Enalaprelate, not enalapril. Clear? After controlling the BP, we can give oral ACE inhibitor. তাহলে first nitroposide, nitroglycerin, then nifedipine, then labetalol, তারপরে fendelopam, then clonidine, then ACE inhibitor, enalaprelate. Nicardipine also a CCB. Fendelopam is a peripheral dopamine 1 receptor agonist. Peripheral dopamine receptor 1 agonist, they direct vasodilates, primarily dilates the renal vessels. Renal vessels dilate hole renin secretion ও কমে যায়. Then natriuresis. ACE inhibitor এর মতোই তারপর থেকে কাজ করে. Primary action is alpha dopamine 1 receptor agonist which is present in the renal vessels, dilates that. So hypertensive emergency, and what are the pharmacotherapy of hypertensive emergency? Hypertensive emergency means there is a accelerated hypertension along plus end organ damage. What are the drugs to be given? First নাম কি লিখতে হবে? Nitroposide, nitroglycerin, তারপরে labetalol, তারপরে alpha methyl dopa, now it a very not very commonly used, clonidine. Clear? Then enalaprelate. এই সবকটা ড্রাগের নাম লিখতে হবে, ঠিক আছে? আর হাউ মেকানিজম অফ অ্যাকশন, ঠিক আছে? nifedipine sublingually can be used. Next is hypertension in pregnancy. Hypertensive emergency is completed. As a short note, you can write down now what is hypertensive emergency, what are the drugs to be given. So next one is hypertensive disorder in pregnancy. It can be chronic hypertension. A patient having a hypertension, having on a antihypertensive, get pregnant, and so the blood pressure will be high from the first trimester only. So there is a chronic hypertension. Then another term is the gestational hypertension. Gestational hypertension means the patient doesn't have a hypertensive symptoms or there is no hypertension recorded, then she got pregnant, and after that after 20 weeks there is a increased blood pressure. So gestational hypertension. Now gestational hypertension, this patient doesn't develop proteinuria or albuminuria, then it is gestational hypertension. But if they develop proteinuria along with there is a pedal edema, then it is preeclampsia. So patient having preeclampsia doesn't develop any convulsion. So that is the patient suffering from preeclampsia doesn't go into the eclampsia. But if she suffered convulsion without any history prior to the pregnancy, any history of convulsion, so there is a convulsion antepartum, intrapartum or postpartum, then that is eclampsia. And this eclampsia patient or preeclamptic patient sometimes develop HELP syndrome. The enzyme or liver enzymes are raised. Liver enzymes are raised. That is called HELP syndrome. So, chronic hypertension is a one entity. Gestational hypertension, eclampsia, preeclampsia, eclampsia and HELP syndrome is another entity. Clear? Chronic hypertension means before getting pregnant, she is already a hypertensive. Patient is normotensive and get after 20 weeks of the pregnancy only having hypertension without any albuminuria or edema. That is only gestational. Gestational hypertension plus albuminuria or proteinuria plus edema is preeclampsia. Preeclampsia plus convulsion, new onset convulsion. New onset convulsion that can be before delivery, during delivery, after delivery within 6 weeks, that is eclampsia. And a preeclamptic patient with deranged liver function, that is HELP syndrome. Clear? So, blood pressure 140/90 before 20 weeks is chronic hypertension. More than 20, 2 occasion after 20 weeks, that is already discussed as a gestational hypertension. Preeclampsia, eclampsia with proteinuria with convulsion. Pathogenesis is not required. Our objective, how we can, if there is a eclampsia, how we can, in chronic hypertension, even after the delivery, their blood pressure will be high. But in case of preeclamptic patient, after delivery, blood pressure will go into the normal range. That difference is that in chronic hypertension, even after the delivery, blood pressure will be high. In case of termination of the pregnancy is a main target for the preeclampsia. So, but we cannot terminate the patient before 23 weeks if we require having the baby live. Clear? So, we have to give some antihypertensive drug so that the pregnancy can reach up to 32 weeks to 34 weeks. Clear? Seizure prophylaxis. In case of preeclampsia, other than antihypertensive drugs, there are some other drugs to be given to prevent. Primarily, this drug is magnesium sulfate, intravenously or intramuscularly. That can prevent convulsion. During this giving of this magnesium sulfate, 3 parameters to be taken care. Number 1, respiratory rate. Number 2, urine output and knee jerk. These are the 3 parameters to be assessed during magnesium sulfate intravenously or intramuscularly administered. And why they doesn't reduce the blood pressure, they reduce the chances of convulsion. Antihypertensive therapy, what are the drugs not to be given during the pregnancy? What are the first line antihypertensive? ACE/ARB, CCB and diuretics. Among these 3, other than CCB, both are contraindicated during the pregnancy. So, if a chronic hypertensive patient having ACE inhibitor or diuretics, because these are the first line drug, most of the patient receive one of these two drugs. So they are receiving this drug and she got pregnant. So then first target is that replace that drug with the drugs or antihypertensive used during the pregnancy. First, but this type of problem is not arise with the gestational hypertension. Why? Because we can detect hypertension only after 20 weeks. So there should not be any situation that patient receiving a ACE inhibitor or ARB or diuretics, but in chronic hypertension there may be a situation for MCQ purpose. The patient receiving a drug, ACE inhibitor, ARB or thiazide diuretics, having a amenorrhea for 6 weeks, USG done, there is a early pregnancy detected. So what is the next step? Stoppage of ACE inhibitor or ARB, starting of labetalol or methyl dopa. These are the first to be done after detection of the pregnancy in a chronic antihypertensive patient. So nowadays first line drug in pregnancy in first line antihypertensive in pregnancy is labetalol, and it is commonly started with 20 milligram, male up to 80 milligram. Commonly, after that hydralazine, nifedipine, rarely clonidine dioxane or nitroprusside required. Methyl dopa is previously taken as a first line drug, but labetalol is now the first line drug. Very rarely we require methyl dopa nowadays also. So for practical purpose, labetalol first line, and then we give nifedipine. Now another thing is that nifedipine we can give nifedipine as a sublingual in case of hypertensive emergency, whereas we preferred oral route in case of when it is used as an antihypertensive in pregnancy. All these drug mechanism of action is already discussed: labetalol, alpha plus beta, nifedipine, calcium channel blockers. And termination of the pregnancy is the main solution of these pre-eclamptic stages. Third topic today is antihypertensive. Which are the antihypertensive used in diabetes mellitus? So hypertension is very common in type 2 because they are both these drugs are the risk factor are very similar for diabetes and hypertension. Prevalence of hypertension is higher in the patient of diabetes than the patient in general population. So coexistence or anti-hypertension and diabetes increase incidence of cardiovascular diseases that lead to increased mortality and augments the risk factors as a neuropathy or retinopathy. Neuropathy or retinopathy is a risk factor. More of these, both these can be complicated due to the hypertension as well due to the diabetes. But when a patient suffering from both diabetes and hypertension, the complication starts earlier and there is a more grave complication of these two, that is neuropathy as well as retinopathy. It has been seen that microvascular complications, both diabetes and hypertension, is very similar. So complications irrespective of age, gender, most commonly BMI also, these complications microvascular as well as macrovascular. Macrovascular means coronary artery diseases. Microvascular commonly retinopathy and renal diseases. Nephropathy also increases. There is a 2 times more chances of stroke if they both diabetes and hypertension coexisted. So which are the drug to be preferred? So commonly the preferred drug is ACE and ARB. ACE, ARB. Other than that, thiazide and CCBs are also given as a first line drug. So all the first line drugs is preferred like general population in diabetic population, but ACE and ARB is preferred when there is a albuminuria. So that required how we can detect that kidney is affected in diabetes. Renal function test means creatinine and urea creatinine. Creatinine clearance, when it detects in creatinine clearance the kidney is already damaged. So microalbuminuria is the detector of that kidney starts to affected. So in that situation, the patient having hypertension in a diabetic, if there is a microalbuminuria, then we prefer ACE more than the CCBs and diuretics. Clear? Another thing is that why ACE inhibitor is preferred more than diuretics. Diuretics have some. What are the side effects of diuretics? তারও আগে হাইপারগ্লাইসেমিয়া করে তো, তার সাথে লিপিড প্রোফাইল ডিরেঞ্জ করে। সো both these are deleterious for the diabetic patient. Number 1 point. Second point, there is a renoprotective effect of ACE ARB compared to the other first line drug. So ACE ARBs are preferred as a first line drug in diabetes mellitus. Then what is the target? Target should be less than 140/90 most of the patient, but if the patient having some more risk factor or risk of coronary vascular disease, our target should be less than 130/80. Clear? For hypertensive emergency, what is our target BP? Reduce 20% up to 20% within first 1 or 2 hours. Then gradual decrease up to 140/90. Here, in case of diabetic patient, our target primarily 140/90. If there is a association or risk factor of coronary vascular disease, the target reduced to 130/80. So therapy, our target is prevent mortality, prevent adverse effect, primarily cardiovascular events, and prevent progression of the renal diseases. These are the main goal of therapies in case of diabetic associated with hypertension. So drugs, ACE inhibitor, what are the drugs to be given? ACE ARB as a first line. Then there is a thiazide and CCB. So ACE inhibitor is preferred when there is a albuminuria, but when it is contraindicated, when we cannot give, when there is already starting of the renal damage, then we should not give ACE inhibitor. Why? Because ACE inhibitor also increase the potassium. Similarly, in a renal failure patient, there will be increased potassium. Similarly, they also dilates the renal arteries. So glomerular filtration will be less. Why we are not preferred ACE inhibitor in renal artery stenosis? CVS তো পড়ানো হয়েছে নাকি? CVS হয়নি? ACE inhibitor পড়ানো হয়নি? So contraindication of ACE inhibitor? If there is a renal artery stenosis, should we give bilateral renal artery stenosis এ কি আমি ACE inhibitor দেব? কেন? ডাইরেক্ট তাহলে কি হবে? GFR কমে যাবে। Similarly, if there is a already damaged kidney, they dilate the afferent arterioles and there is a reduced GFR. So that can precipitate acute on chronic renal failure. So it has to be given before the already damaged kidney. So in albuminuria, ACE inhibitor is the first line drug. If renal already creatinine clearance is very high, creatinine is high, urea is high, we should give other drugs, second line drugs, not the ACE inhibitor. Again, when the patient is on dialysis, the progression is first microalbuminuria, then there is a renal failure, then there is a dialysis, hemodialysis. Patient is hemodialysis twice or thrice a week, then you can give again ACE inhibitor, because during this dialysis all creatinine and urea will be excreted. Clear? So when there is a diabetic patient is on antihypertensive, if only microalbuminuria, we prefer ACE inhibitor. Already damaged kidney, creatinine clearance is very high, not on dialysis, we should stop ACE-ARB. And again, when patient is on dialysis, we can give ACE or ARBs. Clear? So in patients with diabetic and hypertension, blood pressure target should be individualized. Why individualized? Depending upon the cardiovascular diseases. Adverse effect of the antihypertensive medication and patient preference. Antihypertensive preference কখন হয়? মানে এই যে when there is a side effect of hyperkalemia or renal damage, then we have to shift the antihypertensive from ACE inhibitor to CCB. In the primary, if we give diuretic, there may be, we need more drugs to control diabetes because they increase hyperglycemia and they derange the lipid profile. So in first phase we prefer ACE inhibitor, then we prefer CCBs and diuretics, and after that, when already damaged, when there is a dialysis, we can give any other drugs and as the antihypertensive. Clear? So what are the drugs used in diabetes? Antihypertensive used in diabetes, first line drugs are commonly used. So first, why, another explanation why we preferred ACE inhibitor over diuretics as the antihypertensive in diabetic patient. It protects renal, protects renal kidney when there is a albuminuria stage, and in case of diuretics they can derange hyperglycemic control as well as lipid profile control. Clear?